Should I start or have to wait for others? Ma'am? Am I audible?
Yes, you are audible. You can start now. Kindly share your screen.
Yes. Is it visible? The screen is visible or not?
No,
No,
it's
it's
not.
not visible.
Now it's visible.
No. Yes, now it's visible. You can open your PPT now. Yes, good, excellent.
Okay, thank you. A very warm evening to everyone. Now, today's our discussion topic is ocular side effects of systemic medications. I am Dr. Kaushik Sarkar, consultant of Sushrup in Bharanpur. So let's start. After a drug molecule enters the systemic circulation, it usually reaches the ocular tissues through two ways, uveal or retinal circulations. The choroid, sclera, and the ciliary body have thin fenestrated walls through which the drug molecules usually passes. The small lipid-soluble molecules pass freely into the aqueous humor and can further diffuse into avascular structures such as lens, cornea, and trabecular meshwork. Drug molecules that enter the means of uveal circulations, they exit the eye from the canal of Klemm, ciliary body, or may diffuse into adjacent ocular anatomical structures. And drugs from retinal circulation, they can re-enter the systemic circulation from which they have come, or they diffuse into the vitreous cavity, or they can be actively transported out. The accumulation sites inside the eye, in which the drugs are usually accumulated. There are three major accumulation sites from anterior to posterior: cornea, the intraocular lens, and vitreous cavity. The duration of the drug is drug administration is very important. If the duration of the drug is administration is prolonged, then usually the ocular toxicity usually increases. The cornea is a permeable layer, endothelium, inner layer, and so a drug molecule usually permeates through the endothelium and it binds with the glycosaminoglycans which are present in the corneal stroma, and thus it causes corneal edema and decreases corneal transparency. Drug molecules, they can also bind to lens protein and photosensitize the lens to ultraviolet radiations and causes lenticular opacity or cataract formation. And lastly, the drug molecules tend to accumulate in the vitreous cavity due to slow rate of fluid exchange. Some drugs like chloroquine and chlorpromazine, they have a high affinity to melanin inside the eye, and they also tend to affect the ocular tissues. Now, drug metabolism. Coming to drug metabolism, the body's ability to metabolize the drug directly correlates with its toxicity. In patients, usually we all know that anything inside body, they usually got excreted through renal or hepatic pathway. So in patients with hepatic and renal disease, there is a decreased rate of excretion of the drug, which allows the molecules to accumulate to toxic level. And also the toxic metabolites formed elsewhere, like in liver, they can also reach the eye through systemic circulation or can be produced locally in the ocular tissue. Photosensitizers, usually our adult crystalline intraocular lens, they normally filters out most UV radiations. So there is minimal risk of UV radiation affecting the retina, the innermost layer, where the drug molecules can potentially bind. But the anterior structure of the intraocular lens, like cornea, and the lens itself, they are usually get affected by UV radiations when the drug molecules are usually photosynthesized. photosensitized. Exposed lens proteins, which after photosensitization by bound drug molecules, they may denature or opacify the lens proteins, and they accumulate inside the lens and causing cataract formation. UV radiation can potentially affect the innermost layer retina in aphakic and pseudophakic patients because if we can penetrate through normal absorptive lens barrier. And well-known photosensitizers that can cause anterior lenticular subcapsular changes includes allopurinol, phenothiazine, amiodarone, and chloroquine. Now, the basis of ocular side effects of systemic drugs. Some drugs, they have specific biochemical basis inside the ocular tissue, like antimuscarinic drugs, alpha-adrenergic blockers like tamsulosin, and PDE5 inhibitor like sildenafil. As we discussed earlier, that altered metabolism in hepatic or renal pathway, they causes increased drug concentration inside the eye as well as inside the body, and they can cause ocular toxicity also. Like if your liver or kidney failure occurs, renal impairment, that if the patient is having ethambutol or digoxin, so ethambutol or digoxin toxicity can occur in patients with renal impairment. In some patients, there is predisposition to allergy in atopic individuals, which causes Stevens-Johnson syndrome, and there may be toxicity due to overdose of some drugs like quinine and chloroquine. Teratogenicity may occur, and in some cases we see idiopathic or idiosyncratic reactions like diplopia occurs in glitazone, ethambutol, steroid, topiramate, and red tears occurs in rifampicin, which is used in leprosy patients. Now coming to ocular structures and their signs and symptoms when any systemic drug is usually used, and let's start from the cornea. In cornea, due to some systemic drugs, a lesion called vortex keratopathy or cornea verticillata occurs, which is characterized by hole-like corneal epithelial deposits. These are bilateral, fine grayish or golden brown opacities, which usually occurs in the inferior corneal epithelium. Some antimalarial drugs like chloroquine and drugs used in rheumatoid arthritis and like hydroxychloroquine, which is also used nowadays in COVID patients, they can cause this vortex keratopathy. And unlike retinopathy, keratopathy bears no relationship to dosage or duration of the treatment. It is usually reversible after cessation of this drug therapy. Amiodarone is another drug which can affect the cornea. There vortex-like keratopathy occurs, which is slowly reversible on discontinuation of this medication. Higher dose or longer duration of administration is we can find more advanced corneal deposits. But these keratopathy, they are usually not visually significant, so discontinuation is not indicated. And other ocular toxic effects which amiodarone causes, like anterior subcapsular lenticular deposits and optic neuropathy or anti-ischemic optic neuropathy. Yeah. Chlorpromazine and well-known sedative or antipsychotic drugs, they also affects the cornea. Here, innocuous, subtle, diffuse, yellowish brown or granular deposits occurs in the endothelium, basement membrane, or stroma, and it usually seen in the exposed cornea in the interpalpebral fissure. These can also cause anterior lens capsular deposits or retinopathy. It is said that doses greater than 500 mg a day, given for a prolonged period, they have higher incidence of irreversible corneal and lenticular deposits. Agirosis or silver deposition in the cornea. Their discoloration of ocular tissue secondary to silver deposits occurs, and it may be iatrogenic or maybe due to some occupational exposure. This keratopathy is characterized by grayish brown granular deposits in the basement membranes. Conjunctiva may also be affected. Chrysiasis, Here, deposition of gold inside the cornea. Gold is a well-known agent which usually used in rheumatoid arthritis. So, in patient of rheumatoid arthritis, in which gold is usually indicated, in this patient we can find this trichiasis. So, it is characterized by dust-like or glittering purple granules scattered through the epithelium and stoma, more concentrated in the deeper layers and the periphery. Total dose of gold compound of more than 1500 milligram develop corneal deposits. It is also not an indication of creation of gold therapy. And some other ocular tissue also affected by administration of systemic gold, like innocuous lens deposits. Marginal keratitis sometimes happens also. Amantadine, well-known anti-Parkinsonian drugs, they also causes diffuse white punctate opacities that may be associated with epithelial edema, and it usually occurs 1 to 2 weeks after commencement of this therapy. It usually resolves with discontinuation of treatment. Now coming to drug affecting the intraocular lens, as you all know, steroids in any form, topical, systemic, or nasal, drop or spray, they can cause lenticular changes or cataract formation. Now, the patient having this steroid therapy, the lens opacity usually occurs the posterior subcapsular cataract, or posterior subcapsular opacity, or anterior subcapsular opacity. Relationship between weekly systemic dose, duration of administration, and total dose of cataract formation is unclear till now. Patients on less than 10 milligram of prednisolone or equivalent or treated for less than 4 years are usually immune. This said. Children are usually more susceptible to the cataractogenic effect of systemic steroids, and some individuals with genetic predispositions, they may also be affected with this administration of steroids. Early opacities after steroid administration, they may regress if therapy is discontinued. Alternatively, progression may occur despite withdrawal of the treatment, and they may warrant surgical intervention like cataract extraction. The etiology of formation of cataract after the steroid therapy is still not well known. It is said that the drug may react with amino groups of crystalline lens fibers, which causes protein complex to aggregate and forming cataract. Some other drugs like chlorpromazine, they also causes lenticular opacity. Here the deposition is innocuous, fine, skillet-shaped, yellowish brown, and it usually occurs in the pupillary area, center of the lens, under the anterior lens capsule. It usually occurs in 50% patients who have received a cumulative dose of 8 gram, where it is said that the deposit persists despite after discontinuation of the drug. Another drug, busulfan, which is indicated in patients with CML, they also cause lens opacities. Here, it causes innocuous anterior capsular deposits in about 50% patients, which are in which the drug is usually continued for longer than 3 years period. Allopurinol drug, which is usually used in chronic gout or hyperuricemia, they also causes cataract formation. Increased risk of cataract formation is usually in elderly patients if the cumulative dose exceeds 400 gram or if the duration of administration of allopurinol exceeds 3 years. Desferrioxamine and well-known iron chelating agent, they also can cause cataract formation. Now coming to drug causing intraocular inflammation like uveitis, rifabutin. It is an anti-tubercular drug which is usually used in combination with other drugs in immunocompetent patients. So it is said that drugs that inhibit the metabolism of this drug through the cytochrome P450 pathway, they increase the risk of uveitis, like parithromycin and fluconazole. Here, acute anti-uveitis with severe inflammation occurs, which is usually associated with a hypopia. Treatment involves withdrawal of the drug or reduction of the dose and some steroids. Another drug which causes intraocular inflammation of uveitis includes bisphosphonates, which usually used in osteoporosis systematically. Bisphosphonates molecule preferentially stick to calcium and bind to it. They accumulate a high concentration in bones, resulting in maintained or increased bone density and strength. Other ocular side effects, scleritis or episcleritis, blurred vision, and conjunctival hyperemia. Other drugs which causes uveitis includes pseudofovir, which is usually used in CMP retinitis in AIDS patients. There usually vitritis occurs, and along with severe anterior uveitis, hypopyon may occur also with administration of systemic pseudofovir. Treatment includes topical steroids and mydriatics. Now coming to drug affecting the most important layer, the innermost layer of the retina. Antimalarials and the drugs used in rheumatoid arthritis, chloroquine and hydroxychloroquine. They are well-known potential agent to cause retinotoxicity. Chloroquine retinotoxicity is usually dose-dependent. Here, toxicity occurs if the total cumulative dose is increased to 300 gram, or if the duration, if the drug is used for a duration of longer than 3 years. Hydroxychloroquine, though it is said that it is much safer than chloroquine, but it can also cause retinopathy. The risk of toxicity is increased if a daily dose of over than 6.5 mg per kg is administered for longer than 5 years. Hydroxychloroquine. Even the risk is still very small in case of hydroxychloroquine than chloroquine. The chloroquine retinopathy is divided into following stages. First one is pre-maculopathy. Here the visual acuity usually remains normal. Scotoma to a red target usually develops between 4 to 9 degrees of fixation. If we done a Amsler grid testing, it may show a defect. Color vision, if we assess the color vision, we can find mild blue, yellow, and red green defects. In this stage, in pre-maculopathy stage, if the drug is discontinued, chloroquine is discontinued, then visual function usually returns to normal stage. Second one is early maculopathy. Here the visual acuity is moderately reduced. Here subtle bullseye maculopathy started actually, which is characterized by central foveolar island of pigment surrounded by depigmented zone of RP atrophy, which is itself again encircled by hyperpigmented ring. The bullseye maculopathy usually is a characteristic of chloroquine or hydroxychloroquine maculopathy. So in this case, if the drug is discontinued, it may progress to moderate or severe maculopathy. Moderate maculopathy in chloroquine retinopathy characterized by moderate reduction of visual acuity and obvious bullseye macular lesion. In severe maculopathy, the visual acuity is severely reduced up to 636 or 660. And here widespread RP atrophy usually occurs surrounding the fovea. And in end stage, from this picture, we can say that it is like the fundus of retinitis pigmentosa. Here there is clumps of pigments in the periphery as well as the mid-peripheral region. It is characterized by severe reduction of visual acuity, and here marked atrophy of RP with unmasking of larger choroidal vessels usually occur. And as in retinitis pigmentosa, retinal arterioles may be attenuated and pigment clumps develop in the peripheral and the mid-peripheral retina. Other drugs which usually affects the retina includes some antipsychotic drugs, phenothiazine, thioridazine, which causes salt and pepper retinopathy. The Normal daily dose of thyroidazine in schizophrenia and psychosis is 150 to 600 milligram. Overdose of more than 800 milligram per day, they cause a reduction of visual acuity and impairment of dark adaptation. The clinical signs of progressive retinopathy in thyroidazine includes salt and pepper pigment disturbance, which involve the mid periphery of the retina and the posterior pole. Then in second stage, plaque-like pigmentation and the focal loss of RP and choriocapillaris occurs. And in end stage, diffuse loss of RP and choriocapillaris occurs in cases of thyroidazine retinotoxicity. Chlorpromazine, another antipsychotic drugs, they also causes retinopathy. The normal dose of chlorpromazine is 75 to 300 milligram. Larger doses over a long period usually causes retinal toxicity. And it is characterized by non-specific pigmentary granularity and clumping. Now, drugs which causes crystalline maculopathy includes tamoxifen. It is a specific anti-estrogen which is usually used in breast carcinoma. Normal daily dose is 20 to 440 milligram. Here, bilateral superficial fine yellow crystalline deposits occurs in the inner layers of the retina and punctate trailations in the outer layer of the retina in RP. As it affects the center part of the retina, the macular and foveal region, so visual impairment usually occurs. And the foveal cyst formation can occur in case of tamoxifen retinopathy or maculopathy. Optic neuritis may occur in case of overdose of tamoxifen for a longer period, and it is usually reversible. It is said that it is usually reversible on cessation of tamoxifen therapy. Canthaxanthin, it is a carotenoid which is usually used to enhance sun tanning. Here, retinotoxicity occurs as deposition of pinocuous glistening yellow inner retinal deposits, which are arranged symmetrically in a donut shape in the posterior pole of the retina. It is also called gold dust retinopathy. And these deposits, if the drug is discontinued, they are slowly reversible. Methoxyfluorine and inhalant general anesthetic, they usually metabolize oxalic acid, which combines with calcium to form an insoluble salt, which is deposited in the tissues, including the retinal pigment epithelium, and causes retinopathy or maculopathy. Prolonged administration of methoxyfluorine may lead to renal failure and secondary hyperoxalosis. So here, the ocular involvement in terms of sign symptoms, we can say that mild visual symptoms, mild visual impairment occurs associated with calcium oxalate crystals, which are scattered throughout the retina, and they may later be associated with RP hyperplasia at the posterior pole. Interferon alpha and chemotherapeutic drug, they can also causes crystalline maculopathy or retinopathy. Here, some cotton spot and intraretinal hemorrhages occur in cases of high dose therapy of interferon alpha, and it usually resolves spontaneously with cessation of this drug. And it is said that in majority of the patients, the visual prognosis is good after discontinuation of this treatment. Less common ocular side effects with this drug includes hard nerve palsy, optic disc edema, and retinal vein occlusion. Desferrioxamine and well-known iron chelating agent usually used in chronic iron overload. They also causes retinopathy. Presentation is with rapid visual loss, although the fundi may be normal or so mild macular playing in early stages. But in severe stages, after administration of this drug for several weeks, mottling, you can see mottling in retina. If we do a fluorescein angiogram, it shows punctate hyperfluorescence in case of desferrioxamine toxicity. Nicotinic acid which is used as a cholesterol lowering agent. Here, CME or cystoid macular edema usually develop after longer administration of this drug. And if the drug is discontinued, it is said that it is the macular edema or CME is reversible. Now, coming to drug affecting the optic nerve, the first and foremost drug, as we all know, the antitubercular drug ethambutol. It causes optic neuropathy or optic neuritis. The mechanism is it usually chelates copper, so the decreased level of impaired mitochondrial activity of axonal transport in optic nerve causes optic neuropathy or optic nerve damage. So clinically, we can find disc swelling or papillitis with splinter-shaped hemorrhages. And as we all know, in any optic nerve disease, the blue-yellow color vision is impaired. So in this case, also you can have a blue-yellow color vision impairment. Visual field defects in ethambutol toxicity includes two types: central type involves the macular bundle and result in decreased visual acuity, central and centrocecal scotoma, an impairment of blue-yellow vision, and ultimately in second stage, the field constriction occurs, and also the red-green color vision also impaired. In ethambutol toxicity, it is dose and duration dependent. The incidence is up to 6% at daily dose of 25 mg per kg, and rare with a daily dose not more than 15 mg per kg. Toxicity typically occurs within 3 to 6 months of starting treatment with ethambutol. So, if a patient of tuberculosis is having ethambutol, so we should send the general physician should send the patient to an ophthalmologist if the patient is having any visual symptoms or decreased condition of vision. Isoniazid is also an antitubercular drug. It also rarely causes toxic optic neuropathy, particularly when it is given in combination with ethambutol. Amiodarone, well-known antiarrhythmic drug, it also causes optic neuropathy. It is rare. It is said it is rare and it is not dose-related. Presents with insidious unilateral or bilateral visual impairment. So when we see ophthalmoscopically, we can see bilateral optic disc swelling that may persist for a few months if the medication is stopped. Visual field defects includes mild and reversible or sometimes severe visual field impairment can also occur in case of amyotrophic optic neuropathy. Cessation of the drug may not inevitably bring about improvement. It is said that if the drug is stopped, then also the optic nerve damage is usually not reversible in case of amyotrophic toxicity. Vigabatrin, anti-epileptic drug, they also causes optic nerve damage. Patients with vigabatrin treatment, the optic nerve damage usually occurs months or year after the starting treatment. If we see the visual fields in this type of optic neuropathy, we can see bilateral concentric or binasal visual field defects. The defect persists if the treatment is stopped, but do not progress if the medication is continued. So it is said that the association of optic neuropathy with this drug is usually idiopathic or idiosyncratic, rather than a dose-related effect. Topiramate, well-known anticonvulsant drug, they cause optic nerve damage along with acute angle closure glaucoma. The mechanism of acute angle closure glaucoma in case of topiramate therapy is usually due to ciliochoroidal effusion. Presentation is usually within a month of starting the treatment, and it is associated with blurred vision and sometimes halos and ocular pain as far as angle-closure glaucoma. Signs include shallowing of the anterior chamber and increased intraocular pressure. The treatment consists of reduction of intraocular pressure and stopping the drug if possible. The prognosis is usually good and provided the complication is recognized early. My clinical practice, I have seen one patient having treated with topiramate for 2 or 3 months. A female patient, she came to me with attack of acute angle-closure glaucoma. So after getting a thorough proper history, we come to know that the angle-closure glaucoma occurs due to administration of long-term topiramate. Drugs causing dry eye are beta blockers, diuretics, niacin, OCPs, some antipsychotics like phenothiazine, hyaluronidazine, some antidepressants, anticholinergics like atropine, scopolamine, isotretinoin. Drugs which affect the pupil are anticholinergics, CNS stimulants, systemic antihistaminics, systemic phenothiazines. They cause mydriasis, and systemic opioids, heroin, codeine, morphine, systemic anticholinesterase like neostigmine. They cause constriction of pupil or meiosis. Drugs causing myopia are sulfonamides, diuretics, systemic CA inhibitor, isotretinoin, topiramate, and drugs causing cycloplegia are chloroquine, phenothiazine, anticholinergics, systemic antihistaminics, anti-anxiety agents, and TCS. Systemic drugs which increase IOP includes antimuscarinic agents, antihistaminics, phenothiazines, TCS, corticosteroids. And systemic drugs which decrease intraocular pressure includes beta blockers, cannabinoids, cardiac glycosides, and ethyl alcohol. Anticoagulants like aspirin and heparin, they cause subconjunctival and intraretinal or subretinal hemorrhages. It is usually recommended that these drugs should be discontinued for a week prior to any eye surgery. Estrogen or progesterone, they cause decrease in aqueous production, and they also cause microvascular occlusion from enhanced platelet adhesiveness or increase in fibrinogen and clotting factors. So ocular side effects of estrogen and progesterone includes microvascular complications like artery and venous occlusion, dry eye, contact lens intolerance, optic neuritis, macular edema, PIA, and xeroderma cerebri. Rare ocular side effects of systemic drugs includes conjunctivitis caused by anti-anxiety drug like diazepam, phenytoin, carbamazepine. Extraocular muscle paralysis occurs in with some systemic drugs like glipizide, glyburide, barbiturate, and in interferon alpha, oculomotor nerve palsy can occur. Visual hallucinations occur with systemic use of levothyroxine, cimetidine, or ranitidine. Nystagmus occurs with systemic use of lithium, barbiturate, phenytoin, or carbamazepine. Diplopia can occur with systemic use of lithium, anti-anxiety, NSAIDs, and tetracycline. We can have eyelid hyperemia with levothyroxine use, ptosis with chloroquine and barbiturates use, and in chloroquine toxicity we can have visual field changes like paracentral scotoma. Some drugs like amiodarone, levothyroxine, OCPs, NSAIDs, isotretinoin, and tetracycline, they causes xeroderma cerebri with bilateral optic disc edema. Now coming to specific drugs which are which some specific systemic drugs which affects the eye. Coming to tamsulosin, it is alpha adrenergic blockers used in BHP or benign prostatic hypertrophy. Now, use of this drug usually affects the dilator muscle of the eye, the iris dilator muscle, causing poor pupillary dilatation or prolapse during any intraocular surgery like cataract surgery. There is a term called floppy iris syndrome or intraoperative floppy iris syndrome, IFIS. We usually, the cataract surgeon, we usually use this term when we get a patient of cataract who is using tamsulosin for a longer period. Sildenafil, it is a PD5 inhibitor. Ocular side effects of this systemic drug includes color tinges, usually blue or blue-green, maybe pink or yellow. With use of these drugs, the side effects, the darker color usually appear more darker, and some other visual disturbance like loss of visual acuity may occur. Coming to Stevens-Johnson syndrome, it is immune complex syndrome, which usually occurs after administration of some drugs. The ophthalmic pathology involves the conjunctiva, both bulbar and palpebral, cornea, lid margin, and skin, also the eyelashes. In conjunctiva, in mild cases, conjunctivitis or minimal ocular discomfort and photophobia occurs. In severe cases, there is pseudomembranous and membranous conjunctivitis, discomfort and photophobia. The raw surface can lead to adhesion formation between the palpebral and bulbar conjunctiva, known as symblepharon. Contracture of the eyelid and palpebral conjunctiva may occur, which causes cicatricial ectropion. Lid margin inflammation can occur, which can cause widespread destruction of the meibomian gland orifices and the gland themselves. The eyelash architecture, they can also be affected, resulting in trichiasis and dystrichiasis. Sometimes keratinization of lid margins and palpebral conjunctiva further contribute to discomfort and corneal damage by being created macrotrauma to the corneal epithelium. To summarize, a careful and detailed case history is important to reveal a patient's medication history. The ocular and visual side effects from a patient's systemic medication can range from mild to severe. Side effects may or may not be serious enough to warrant discontinuing treatment. Recognition of ocular and visual side effects is important for prompt management to prevent and minimize serious complications. And familiarity with medications improves by routinely paying attention to concomitant medications. Thank you. This is actually an uncommon topic. It is not clinically so much important, but you should know actually what systemic drug causes which type of ocular toxicity. Any questions from your side? No questions. Should I finish here? Okay. Thank you all for your kind attention.
Thank you, sir.